I'm Peter Boland, and this is More Health, Less Healthcare. As part of our 7 segment series, I want to address the fact that few employers use their leverage in the marketplace to significantly reduce employee healthcare costs. And what happens when they do? And this goes to the heart of the series, what I'm calling, What If They Got the Incentives Right? And I want to highlight few employers who actually use their leverage, used a different model and a non-traditional hands-on approach. They took concrete action and produced very different results that we can all learn from. And employers have this enormous purchasing power, a direct stake in the health of a defined population, and almost no structural incentives to extend the status quo. And yet, most of the time, they act like passive consumers of whatever the insurance industry chooses to sell them. The fact is, the employer pays a significant share of the premium. The employer bears the productivity costs when employees are sick, undertreated, and even burned out. And the employer has the most direct relationship with the working age population, the demographic that sits at the center of private health coverage in this country. And unlike a health plan operating at a population scale, the employer knows their people. They know what their workforces need. They know what their community looks like. So this episode is about what happens when employers stop being passive and start acting like the sophisticated health investors they have every reason to be. And what becomes possible when the savings they generate go back to the communities where their employees live. I'm talking about Health Rosetta and the driving principles that change everything in the marketplace. And Dave Chase, their founder and CEO, and Health Rosetta start from a straightforward premise. Organizations should manage their healthcare spending the way they manage their employees' retirement plans, with rigor and transparency and with aligned financial incentives and with accountability for outcomes. That sounds obvious, and in practice, it's actually radical. The Health Rosetta model has 8 components, and I want to touch on each of them with you. First is transparent, open networks with known prices and outcomes focus. Second, individual stewardship that incorporate each employee's health profile and preference for advanced primary care with proper incentives. And third, active and independent plan management with ongoing oversight. And then transparency pharmacy benefits and appropriate handling of major specialty and outlier cases, and high performance plan design, and transparent relationships with benefits advisors who have aligned and not conflicted financial incentives. The through line across all these 8, it's the same. Remove the conflicts of interest, align the incentives, and attach everything to outcomes. It sounds deceptively straightforward. Now, Health Rosetta's own materials put a number on the opportunity. I guess they call it the Rosetta dividend. Many employers have 30 to 50% of current spending tied up in waste and overpriced care, recoverable through more insightful benefit redesign. The model is particularly powerful employers who choose to self-insure, which means paying employee claims directly rather than paying a carrier a premium and hoping for the best. Self-insuring removes the carrier's margin from the equation, gives the employer direct visibility into where their healthcare dollars are actually going, and then opens the door to benefit designs that the standard insurance market simply doesn't offer, at least not very often. And the firm is clear about what it takes. It takes a benefits advisor with a mindset of a retirement plan administrator, someone with real financial and statistical skills, not a traditional broker whose incentives run towards the products that pay the highest commissions. And that distinction matters enormously. Most employers are working with advisors whose financial interests are misaligned, often misaligned with the employer's cost control goals. Health Rosetta corrects that. And the model isn't just for certain sized employers. Small employers can form self-insurance consortiums so that even organizations with fewer than 50 employees can use this model. And that's a significant development for rural communities and smaller cities where few mid-sized employers are often the dominant healthcare purchasers in the local market. So let's look at Rosen Hotels in Tangelo Park to see what a savings dividend looks like. Now let's talk about what happens when an employer actually executes on these principles, because the Rosen Hotel story is the kind of thing that should be required reading for every CFO and benefits director in the country. So Rosen Hotels and Resorts in Florida apply their Health Rosetta style principles to the self-insured health plan. Over time, they generated more than 540 million in savings compared to what they would have spent under conventional employer coverage, a single employer case drawn from a 225 interview about the model just a couple of years ago. So it's worth reading as a demonstration of what's possible at this scale rather than a typical outcome. Now, here's the part that makes the story different from a standard cost containment success case. Rosen didn't just pocket the savings. The CEO invested 5% of those savings, that's 13 million over 25 years, into Tangelo Park, a low-end community in Orlando where many of his employees live. The investment focused on children and education, early childhood education programs, college scholarships for every child in the neighborhood who graduated high school, and support infrastructure that created a genuine ladder of opportunity in a community that had previously very little of either. Now, the return on that 13 million investment was $90 million. High school graduation rates climbed. College degree attainment rose dramatically from 9% of college going rate typical of such communities to outcomes that resemble far more advantaged neighborhoods. And crime rates dropped 98%. That's right, 98%. Now, this is what an employer's savings dividend invested in community development actually produces. Not a marginal improvement, a neighborhood transformation. And the mechanism that made it possible wasn't a government program or even a foundation grant. It was an employer who decided to run a well-managed health plan and then invest the difference in the people who showed up to work every day. Let's look at how this model scales before anyone concludes that the Rosen Hotel story is, well, a one-of-a-kind outcome driven by an unusually committed entrepreneur. That's not the case. So consider the Ashtabula County School District in Ohio, which applied Health Rosetta principles to their employee health plan with far more modest resources and still generated $2.4 million in savings. And that's a 20% year-over-year reduction. Small employers tell the same story at a smaller scale. One Health Rosetta case example shows a single employer's projected monthly health spend dropping from $66,000 a year to $56,000 a year, while lowering employees' out-of-pocket exposure. What they got was savings and better coverage at the same time, not a trade-off between coverage and savings. They got both. A typical school district, 20% savings in 1 year. And this isn't a boutique solution, just for large, sophisticated employers. The principles work because they're based on removing structural inefficiency, aligning incentives, and paying for value. Now, those aren't scale-dependent conditions. They're conditions that most employer health plans currently violate, regardless of size. And we have to ask the question, why don't more employers in your community consider this model? What's the barrier? Because the incentives in most traditional health plans do not get the incentives right. Let's take another example. Let's look at another build health challenge, similar to the example cited in the previous podcast. Now, the Build Health Challenges Spark initiative in Oakland makes the complementary argument from the community side. When employers and anchor institutions invest in the social determinants of health, the drivers of health in their communities, the return flows back through a healthier, more stable workforce. It's an investment that pays tangible dividends. At the Spark Initiative, more than 500 community leaders mobilized around transportation, culture, affordable housing, and economic development along the San Pablo Avenue transportation corridor. That's not an abstract community benefit initiative. That's an investment in the conditions that determine whether employees can get to work reliably, whether their children are healthy, whether their neighborhoods are safe, and whether they have any reasonable shot at economic stability. The Spark Project realized that the pathway to better health was through economic development and social investment. Better health became a reality through community investment. And employers who operate in communities like this have a direct financial interest in those outcomes. And the question is whether they see it that way and whether they're willing to act on it. So I want to close by noting that the employer is the most underutilized actor in American healthcare. And that's a choice. It's not a structural inevitability. Health Rosetta has documented the principles. Rosen Hotels has documented the return. Ashtabula School District has documented that scales down as well as scales up. And the Build Health Challenge has documented that community investment produces when it's done with community leaders driving the priorities. But what's missing in most cases is the board level decision to stop being a passive purchaser and start acting like a health investor. And that decision doesn't require a legislative change or a new federal program. It requires an employer who looks at what they're spending, decides to spend it better, and then asks what to do with what's left over, the dividend. The organizations in this episode answered that question, and the rest of the employer community is largely still avoiding it. So in the next episode, we're going to turn to organizations that asked their communities directly what they needed, and then they did something genuinely unusual. They listened. And that's the next episode. I'm Peter Boland, and this is More Health, Less Healthcare.